Okay, so hi, happy Saturday. I cannot believe it's already weekend, and I'm so happy to see you all right now. This is a VMR very special for all of us because it's like international VMR where we can speak all our languages and we are allowed to say I don't know all again and learn other languages, and this is one of my favorite VMRs on the weekend. And well, I'm Kiara. I forgot I'm Kiara. Some of you already know me, and I'm from Peru. I'm a medical student from Peru. I'm last year medical student. I should have end already my education. However, COVID happens, and I don't know when I will be finishing. And well, I know a little Portuguese, and I remember Ravi told me that 2 weeks ago I have to talk in Portuguese, so I will try to talk in Portuguese a little bit. So, hoy meu nome é Chiara, eu sou estudante do último ano no Peru. Estou muito contenta de vê-los a todos vocês. Eu acho que combinei português e inglês. um, so I would like to Sukriti to introduce herself. And of course, please, if you have a case, please present to all of us. I will be amazed to hear it.
And before Security jumps in, I'm curious, Marcela, how was Kiara's Portuguese? How did she do?
Kiara, you were great. Muito bom. Amazing. Really love it.
Hi everyone, Namaste. मेरा नाम सुकृति है, which in Hindi is my name is Sukriti. I'm from India, from Bangalore, and I'm super excited to join today's VMR. And now I give it to Ravi. I don't see Rafa on the call yet to introduce himself.
Yeah, Rafa is having internet issues, I believe. Ahla wa sahla, which means hello in Arabic. My name is Rabi. I'm originally from Lebanon. I grew up mostly in Pakistan and then came to college here in the US. I see somebody who is ever present in VMR, who Sherry, who just wished happy weekend to everybody, and then has characters typed out that I don't recognize. Sherry, do you mind unmuting yourself and tell us a little bit more about you?
Hello, everyone. I don't know if you can hear me. I'm actually at the airport.
Whoa.
I'm Sherry. I'm a fourth-year medical student going to internal medicine. I'm actually flying back to Taiwan now
amazing.
to see my family.
Aww.
Super excited.
That's so cool. How long are you going to be in Taiwan for?
For 2 months, almost 2 months.
Amazing. And where are you going for internal medicine?
UCSF.
Woo! I secretly knew that, by the way, Sherry. That was a leading question. It's polite. I'm so excited to be able to work with you in person. It'll be a lot of fun.
Oh, thank you so much. Super
I'll
excited.
have to ask you about how about your trip to Taiwan when we actually meet in person.
Thank you.
So what did you type in the chat? There you said happy weekend. Yeah.
Yeah. 周末愉快, which is just like happy weekend.
Can you say it again one more time?
周末愉快.
Wonderful. Oh, that sounds so cool. Amazing. All right. Well, I hope you were able to join us from Taiwan, though. If you're exclusive with family time, that makes a lot of sense. And congratulations again.
Thank you.
Of course. Okay, y'all. Oh, by the way, Sherry, it looks like Kiara has an open invitation for you to go to Peru if you ever decide to.
That will be amazing.
Oh, that's wonderful.
Thank you, Kiara.
You're very welcome, Sherry.
I don't know if he will, Drew. I don't know if he will. He's actually pretty quiet, but who knows? A poop can come anytime. So I don't think I see anybody who has volunteered to present a case yet. But I actually want to wait one quick sec, folks. I have an idea. Give me a second. I'll keep an eye on the chat in the meantime. One moment. Okay. Okay. I'm going to do something maybe a little uncool, but I think, Preeti, you just sent an email to the CP solvers maybe within the last 12 hours. If you're on the call, do you want to unmute yourself and tell us about yourself?
Hello everyone, I'm Preeti Agarwala. I'm a medical graduate from Bangladesh. I live in Iowa in the USA and আমি এখানে আসতে পেরে খুব খুশি. That means I'm very happy and excited to be here.
That sounds amazing. Preeti, I recognize one word which is identical in Urdu, khushi, which means happy. So I got that thread. So tell us more about
Awesome.
your life in Bangladesh. When did you come to Iowa?
Okay, so yeah, my husband is doing a PhD at Iowa State University. So I came here, then I'm planning to enter into the next residency match in
Amazing.
internal medicine in the US. So yeah, that's the plan.
Well, thrilled to have you. Have you been to VMR before?
No, actually, I've been following VMR podcast and episodes for a long time. But actually, I didn't come for any this live sessions.
I
But
see.
yeah, but I have been joining from yesterday.
Oh,
Yeah.
wonderful, wonderful. And in your email, you said you have a case. Do you think you want to present that today?
Oh, okay. I thought actually I didn't prepare that much,
I
and
see.
I think I should have scheduled it for a specific day or something like that. So that's why I emailed you guys.
I see. You know, if you take a look at the chat, one of the things that we pride on in VMR is actually like presenting it just from your heart and not your brain. Quite honestly, it's way more fun and way more engaging and way more authentic.
Mm-hmm.
As Kushal just said, is a very safe space. And I know Gurbani is here, and Gurbani presented on last weekend a case like essentially from the mind and from the heart. So um, if you're up for it, we'd really want to, but of course we totally understand if you want to wait. So it's really your call, but we really encourage you to present it whatever you remember. It doesn't matter.
I really don't have those things, and
Okay,
I
yeah.
actually I'm out. I'm driving. I'm in the car.
Okay, no
So
problem at all. No
yeah,
problem at all.
but
Yeah.
yeah, I'll definitely want to. I want to do it like next week or
Okay.
something like that. Yeah.
Amazing. All right. Hey, it looks
And
like Han has a case. Han, unmute yourself, please.
Good morning. I'm Han and I'm from Vietnam. And I have prepared a case and I'm happy to present the case tonight. This morning, sorry.
No, it's tonight. What time is it in Vietnam?
11 p.m.
Wow. You know, I'm in my REM cycle at 11 p.m. So I really commend you for being up this late and being here in VMR. Thank you so much. We really thrive on your presence here in VMR. And if you haven't checked out Han's tutorials, she does periodic tutorials recapping a VMR on Twitter, which is absolutely amazing. Thank you so much, Han. And Preeti, we really look forward to your case whenever you're able to present. Maybe when you're not driving. We look forward to it. All right, Han, jump on in, please. And I would love for you to tell us the chief complaint in English and also just so we've heard it in Vietnamese as well.
My other quick one is chief complaint is a fever. This is a 9-year-old boy who presents with 3 days of fever.
And Han, you said 94, right?
9 years old, sir.
Oh, okay. So this is a pediatric case. You already got me a little nervous, but that's okay. We have so many people here. Can I ask you, how do you say fever in Vietnamese?
We call short.
Sure.
Fever is short in Vietnamese.
Wow, amazing. Thank you for sharing that.
Yes,
Kushal is
sir.
already, even with such little information, Han, Kushal is already on fire. Kushal, do you want to unmute yourself and tell us where your mind started to go?
No, that's just an empiric response for any fever differential diagnosis. I start out with TB, malaria, and histo.
Amazing. And how come?
just based on the base rate and considering infectious causes don't recognize the age, it can present at any age.
Yeah.
So that would be the first thing that comes to my mind. And as the case progresses, I will change the DDX. Yeah.
Love it. No, I love it. It's amazing how common those diagnoses are. Like TB, histo, and malaria are present worldwide. They're incredibly common. They're very hard to diagnose, and I think they have to be on our minds all the time. I love it. And it looks like Gurbani is using a mnemonic. Gurbani, please unmute yourself and do you want to teach us what that means for you?
I think it's your mnemonic.
It's not my mnemonic. It is my older brother's mnemonic, but it is yours now since you know it.
So basically, fever translate to like inflammation. So you think of infectious, malignancy, autoimmune, drugs, and endocrinopathies.
Amazing. And since we have you here, do you want to just share where your focus is? So you have all these options. What would you start off with?
Since it's let's see. I think I would think more so infectious because it's a little peds. And then I might think autoimmune as well.
I love it. So you're saying like, the most morbid and the most acute is infection, but then, you wonder about what Dhruv mentioned earlier, to think about NGLA and then wondering about autoimmunity. I absolutely love it. And I think, Mathira, you're sharing to us like hyper acutely from the ER perspective. Do you want to share those reflections?
Yeah, so whenever a patient comes in with fever, obviously the differential diagnosis is extremely large, but the four things that you gotta go through before allowing yourself to think about other things are infectious. I think to try to think system by systems, if that system could be infected. Then environmental, because we get full a couple of times a year going like pursuing a septic diagnosis while someone is having a high fever, but it's from an environmental cause. Usually it's older people. They comes in, they're like 41 degree Celsius. They get covered with antibiotics, and instead of focusing on bringing that temperature down. The other thing is endocrine. The two things that comes in mind is thyrotoxicosis and adrenal insufficiency. And then the toxicologic cause, again, people can get full pursuing a septic diagnosis while the person is intoxicated with any symptomatic anticholinergic or in withdrawal. So these are the four buckets that I open each and every time before allowing myself to close on a diagnosis or think about more subacute to chronic pathologies.
Absolutely brilliant. That stands by itself. Thank you so much for sharing that and being on the front lines. It really is informative how when you meet a disease, what you have to think about right away, and then what you have to think about afterwards. I saw Amanda made a comment about a specific syndrome with meningitis. Amanda, can you tell us more about how you think about that?
Hi. I'm sorry, I don't speak English very well, but
yes,
I can explain.
Tell us where you're calling from.
Brazil.
Amazing. Do you want to
Minas
say hi?
Gerais. Hi, everyone.
Hello.
I think about the age is very specific, and meningitis is very common. We see a lot in my city. So I think, but not specifically, I just think.
Yes, no, I think that's very important. The age of the patient really determines how we work them up. And I completely agree with you. I think that one of the most life-threatening causes that we have to think about is meningitis. And it's no different to what Kushal said. Maybe, depending on what we find, the probability of TB, histomalaria may be low and the probability of meningitis may be low. But you have to think about them. You really, really do. So one second. Yeah. where are we at? We're we're prioritizing infectious causes. We have to expand the horizon to autoimmunity. And Mathieu taught us that actually when you're meeting a fever for the first time, you have to have a prioritized approach based on the fact that you're making contact with the fever for the first time. And so this is how I think about it. It's very similar to Mathieu's approach, which is the priority almost always is on infection. And what helps me remember the other causes are the 3 H's. And that's hyperthermia. And as Mathieu was alluding to, from exposure like heat stroke, from drugs like NMS, hyperthyroidism can cause a really high fever, and then heme. So you never want to miss a microangiopathic hemolytic anemia like TTP on day 1. So these are the things where I start with fever, and I have to think about all these things: infections, both common ones, and then using localizing clues to prioritize some, hyperthermia, like exposure, hyperthyroidism, and heme, so the 3 H's. All right, Han, why don't you give us more, and excited to dissect this case further with this amazing crowd.
I start my alloquat. I continue to my alloquat one. This is his mother reported. Day one, his temperature at home was 38 to 39 Celsius. He had cough with small volume of white sputum. His fever was slightly improved when he took antibiotic drug. On day two, he continued to have fever associated with nausea and anorexia. He visited to a pediatric hospital and he was diagnosed with acute respiratory infection. On day three, his symptom didn't improve with treatment of respiratory infection, and he visited to a city hospital. A review of symptoms: he had abdominal pain, vomit, and nausea, dyspnea, Jordan, or seizure. In terms of past medical history, he was delivered by cesarean because his mother suffered oligohydramnios and prolonged pregnancy. Uh, he had a febrile seizures when he was 3 years old. He had no allergy to food or medication. He had updated vaccine and he has no on substance or any medication. Um, in terms of family history, he had no, unremarkable. The social history: he lives in southern Vietnam and he is a primary student. There's no report of fever cases from his classmates. However, there are 2 reports of people suffering dengue hemorrhagic fever who live in his area. And that concludes my alloquat too.
Incredible. Thank you so much. May I just clarify, Han, did he have abdominal pain? Is that?
Yes, he had abdominal pain.
Terrific. And then you said that some people around him had fever or did not. I didn't quite catch that. You said his,
Sorry,
yeah.
could you repeat question again?
Somebody that he knew had a fever. Is that what you said?
Uh, this is a new fever.
Okay. Terrific. Thank you so much. So, thank you so much, Han. I'm just scrolling through the chat. We're talking about stuff we reflected on with Echinococcus specifically last week, and I'm looking at the chat. Maybe I'll get us going, and then I think Travis, can you just explain what you just said? The center of gravity of lungs. What does that mean to you?
You know, I think kind of with, like you mentioned with the infection, you know, I think lots of things can cause fever, and important to finding, you know, a center of gravity, whether it's the skin, it's the CNS, it's the urinary tract, you know, if there's flank pain, if there's any urinary symptoms, and kind of focusing on that. I know sometimes certain infections can give you, you know, maybe affect 2 organ systems. So, you know, you try to see if there's any overlapping, you know, illness scripts for abdominal pain and coughing or things like that. But I think with the coughing, that's kind of where my focus would be, and that would really help me with testing and imaging. What my next step would be involving getting some chest imaging.
100%. Yeah, Matthew teaches us the holy trinity of dyspnea: chest X-ray, EKG, and ultrasound. I absolutely love it. Gabrielle, you're teaching us a little bit about primary TB in children. Can you unmute yourself and tell us more?
Yes, sure. I'm currently doing my PETS rotation and just in a case of primary TB and in a children presenting with pneumonia. And my professor told me that primary TB presentation is common among children. And it's kind of like this presentation: cough and fever, maybe abdominal pain, because abdominal pain is very unspecific in a pediatric patient. And that's a thing we should consider because we gotta keep track of the contacts of TB, because we don't want to keep continuing spread the TB.
Absolutely brilliant. Thank you. And another diagnosis that is on people's minds is Kawasaki's disease. And Gurbani is teaching us that you need 5 days of fever to make that diagnosis. Gurbani, can you teach us a little bit more, like maybe what you know about this disease?
Yeah, sure. So the mnemonic I remember is crash and burn. So you need 5 days of a persistent fever, and then it's usually most common in toddlers. So this patient is a little bit outside of the age range. And then for the symptoms, you want to see mucositis. So you get the classic pictures like a strawberry tongue, lymphadenopathy, cervical lymphadenopathy. They get conjunctivitis with limbic sparing. They get peripheral edema, and then they get a maculopapular rash. And then I don't know how many of those things I listed, but you need 4 out of the 5 of those to make a diagnosis. And then if you have 2 of the 3 of them, you can have atypical Kawasaki disease. And the treatment for it is IVIG with high dose aspirin. And that's usually done for, and the reason you're giving the aspirin is because these patients are at increased risk for coronary artery aneurysms. So they'll need an echo. You usually want to get an echo on them, and then they'll need follow-up as well for echo after they are hopefully treated. And they also can't get the MMR vaccine, or basically live vaccines have to be delayed for 11 months because you give them the IVIG. And if they don't respond to the first dose of IVIG, they get a 72-hour window they can spike fevers within that time. If they don't, they can have refractory, and you can consider giving them another dose of IVIG. And then once, so what I've learned on my peds rotation is that often with the high dose aspirin, you have to be careful because you can shut down their kidneys. So usually what they do in clinical practice is tape, like once they are afebrile, they'll lower it down to a low dose aspirin for outpatient continuance.
Love it. That was absolutely brilliant. And you hit everything. Gabrielle shared a really nice mnemonic: CREAM, CREAM, conjunctivitis, rash, edema, adenopathy, and mucositis, with of course the feared complication of coronary vasculitis and aneurysm formation. I love it. I don't think I have anything to add. I think the question here, as Travis alluded to, is what is the center of gravity of this case? And the cough is very concerning, that there's something going on in the lungs. And then we probably have to pay attention to the abdominal pain. And then this is all in the understanding that our focus is on infection, but as Matthew said, we can't miss other causes of acute fever like exposure or hyperthyroidism, and have to be open because of the age of the patient to other less common causes. So and of course, in the back of our minds, we're wondering, he's been exposed to 2 reported cases of hemorrhagic fever. Is this what's going on? And I just saw a comment from Dhruv about something I actually have never heard of. Do you want to elaborate on this, the MISC?
And I think I had also mentioned this maybe a couple of, I'm trying to remember exactly, that this is a syndrome, or so the multi-inflammatory system related to COVID can actually occur in both children and adults. The adult symptom is, or the adult syndrome is a little bit heterogeneous, and there are multiple things that can happen with it. But in children specifically, it acts a lot like Kawasaki disease. And there is and it's one of the big differentials now that you have. Usually, like prior to COVID, it was basically like, oh, this is classic Kawasaki disease or incomplete or whatnot, and you would have it. But now you have to consider, oh, did this patient have COVID? And one of the symptoms that can be characteristic of MISC is abdominal pain, which you usually do not see in Kawasaki disease.
Got it. Amazing. Thank you so much. Super, super helpful. All right, Han, do you want to give us more information?
Yes. The next other quote is a physical examination. The temperature is 38.5 Celsius. His pulse rate is quick and rapid. The 110 ppm. The blood pressure is 80 over 70 millimeter. The respiratory is 28, and the saturation is 98%. Over the fraction oxygen 32%. The generation his alert and dry appearance. He had pink eye but dry mouth and no GVD. His cardiovascular exam is unremarkable. The pulmonary exam is a normal resting sound and no rouse. In terms of the abdominal examination, he had tenderness in the right upper quadrant, palpable liver 2 cm below the right costal marine. The extremity he hand is cold, and the CRT is 4 seconds. No rash, no pediatry. The neurology is he had no focal neurologic deficits. The lab revealed that the white blood cell is 3.42. The neutrophil is 7.4%. The hemoglobin is 4.73. The hematocrit is 50% and is reduced to 40.5%. The platelets is 107. The AST and AST is elevated. The AST is 60 and the ALT is 50 and 7. The glucose is the 90 and 7. This is my alloquatry.
Amazing. Han, can I ask you just 2 questions? Can you please repeat the skin exam for us?
The skin exam. I don't have a skin exam.
Oh, you said, is there a rash or no rash?
Yes, no rash.
Okay, thank you. And what was the hemoglobin?
The hemoglobin is 4.7.
Oh.
4.7.
So the white count, hemoglobin, and platelets are all low.
Yes, sir.
Ooh, uh-oh. Okay, all right, let's put our thinking hats on, and I'm going to scroll all the way back to ask our new friend Preeti to tell us how she got to thinking about typhoid. I think that's a very important thing here.
Okay, so actually, what I can remember, the fever comes first in case of typhoid, yes, and then the abdominal pain. But as she said that there is no rash, so I can't remember, but the rash comes later, I guess.
Yeah.
A few days later, yeah. So I don't know if that can go towards the typhoid fever, but yeah, because of the fever and the abdominal pain, I thought of typhoid. But now, as she said that there is a right upper quadrant pain and palpable liver, so I thought it could be some parasitic infection because the patient has less hemoglobin as well.
Yes, I love
So
it. I think that's a brilliant thought. Any acute fever in many parts of the world, you have to entertain typhoid fever. And the problem with typhoid is we think about it as a gastrointestinal organism, but it really is a systemic organism with gastrointestinal features. So patients have pneumonia from salmonella, patients have all sorts of systemic symptoms. So really, thank you so much for bringing that up. I really think it's very, very important. And then I just want to move on to studying the current syndrome, but I can't help but emphasize one thing that Karen taught us. So Karen, do you want to unmute yourself and tell us how you use the age for Kawasaki versus MISC?
Hi. Well, in my pediatric classes, some doctors say to us that it's a great point to difference the age in the MISC cases that they have been treating. They notice that it's a great difference in between this disease from Kawasaki disease. Kawasaki disease is usually they have patients with 5 years or less, and now they have been well when the pandemic started, they said, oh my god, Kawasaki disease in child that are older than that. So it's a great point to difference, at least as a from my doctors what they said me.
Yeah, this is very, very helpful. Thank you so much. Can you tell us where are you calling from, Karen?
I'm from Peru.
Oh, from Peru.
I was very nervous to talk in English. I already know that you noticed that it's not very good.
You did such a good job. It was really, really good job. Thank you so much. There's no nervous here. We're all learning together. This is the whole point of this, is to have people like yourself join us. And you got a clap from Renato. You see that? Who was very quiet in the chat today, but I see that clap. Okay. Thank you so much. I want to. I have a reflection to share with you, and I think I'll share that in a moment. I just wanted to have Hans share his thought about aplastic anemia. I think it's an important one here, and we'll talk about it in a second. But Hans, unmute yourself, please. Tell us where you're calling from and your thought.
You call me Dr. Ravi.
Hello.
Oh no, I called Hans. Very close.
Yes, I'm calling actually from Germany. I'm from Canada. I'm visiting my mom. And we can see a decrease in hemoglobin and other blood components under certain circumstances involved with viruses. But I'm not very familiar with the viruses in the jungle like in Vietnam. So this could be dengue fever, chikungunya, yellow fever, anything that I'm not even familiar with.
Brilliant. I think that virus to aplastic anemia is a very, very important one. I think it's a great thought. And the timing of VJ couldn't be better. VJ, do you want to unmute yourself? Tell us where you're calling from and the thought you just mentioned, which I think is very good.
Good evening. I'm from India, currently a medicine first year resident from Bangalore.
Welcome.
Like traditionally it is taught that usually a young patient in pediatrics, the short history of fever, usually we think infectious being the first cause.
Yes.
Most commonly it is viral when the patient is fairly preserved with fairly high grade fevers and in the background of pancytopenia. Most commonly we think of a transient viral suppression, or it could be secondary. I would like to have a peripheral smear. Peripheral smear. what if it could be a presentation of an acute leukemia presenting as fever? Because we had the eye made mnemonic that had a fever having malignancy as a cause there.
Amazing.
And most common, we would have a parvovirus causing a transient aplastic crisis.
Yes, I love that, Pearl. Great analysis and a great Pearl to end. Thank you. And my dear friend Rob Weber has a great short list of infections. Rob, please unmute yourself and share them.
Oh gosh, I don't think I have more to add than the list, but I will say this list was generated from a great New England Journal of Medicine CP solvers case called a treacherous course. I won't give away the diagnosis, but yeah, the list is basically viral, bacterial, or parasitic. So CMV, EBV, dengue, as was already mentioned, Q fever, lepto, hantavirus. I don't think there's any of that in Vietnam, but I don't know for sure. Anthrax, and then mycoplasma.
Amazing. Thank you for typing it in the chat. And I think a lot of people don't get to see the chat when they listen to the recording. So having them hear that directly from your brain is very valuable. Thank you so much, Rob. Okay. All right. We got to move on, but here's what I'm going to share. I think what Travis said initially was, what is the center of gravity of this disease? And now I think we have a place to drop the anchor, and that anchor is pancytopenia. And pancytopenia is very, very daunting. There's a differential diagnosis that's extensive, and we haven't shared this on the app yet, and hopefully want to perfect it before we do that. But I think the key question with pancytopenia isn't what is the cause of pancytopenia. It's too extensive to have one schema for. So you have to have a variable to break it down by. Otherwise, your paper will be full and useless. So the one filter to apply through pancytopenia is what Travis was into is the center of gravity. If the center of gravity is meant to imply, what does the syndrome entail? And does the syndrome entail just cytopenias alone and nothing else? And if that's the case, then you landed on impaired hematopoiesis. B12 deficiency, alcohol, methotrexate, aplastic anemia, there's only involvement of the marrow and there's not much else going on. In stark contrast to a case like this, where this is pancytopenia in the context of a systemic syndrome that involves fever, involves the lungs, involves the abdomen, involves the liver. And so we're probably here. The one cause of impaired hematopoiesis that can move from marrow to systemic is AML or ALL, any acute leukemia. The idea is these syndromes, MDS, aplastic anemia, and all these ones, just disproportionately affect the marrow without much systemic signature. And there's one exception to the systemic signature which Gabby, who I don't think is here, would appreciate, is that these syndromes have a lot of neurological overlap, B12, hypopit, alcohol, methotrexate, but they're usually systemically silent. So we're probably here. We're probably either dealing with, as Vijay said, an acute leukemia or a loss of red blood cells from splenomegaly, which we didn't feel, from tick-borne diseases, which are really important to think about with acute fever, pancytopenia, and liver enzyme elevations. You have to think about lupus in this context. I can't tell you how easily it is to test for lupus with an ANA, but how easy it is to miss. And people were talking about smudge cells in the chat that would be evocative of CLL. These are all things that destroy white blood cells, red blood cells, and platelets. But what about things that infiltrate the bone marrow? And this, we have to think about a metastatic malignancy, which is unusual, but lymphoma going to the bone marrow is certainly possible. Granulomatous infections are key here. And what do we mean by granulomatous infections? Things like TB, brucella, salmonella, and the endemic mycoses. All those have a propensity to go to the bone marrow. And we already heard from Preeti about the possibility of salmonella doing pancytopenia, abdominal pain, cough, fever, et cetera, et cetera. So as you're thinking about pancytopenia, don't think about it until you have the center of gravity. And if the center of gravity is just the bone marrow, it's systemically silent, prioritize these causes. But if there's a systemic signature, it's either destruction by splenomegaly, tick-borne infections, lupus, or CLL, infiltration by a malignancy, or granulomatous infections. Which granulomatous infections go to the bone marrow a lot? Mycobacteria. We had a case from Kushal, Mycobacterium avium going to the bone marrow. So mycobacteria, brucella, salmonella are the priorities, although any bacterial can do it, and all of the endemic mycoses, with 3 more common than the others. And the 3 endemic mycoses that go to the bone marrow are histo, Telaccomyces, which is endemic in Vietnam, and Paracoxi, which our Brazilian friends are experts in. Okay, all right, Han, I'll give the mic back to you.
This is my last aliquot with a final diagnosis. He has a NSA1 positive, and the final diagnosis is a dengue shock syndrome.
Han, can you teach us more?
Sorry.
Tell us more how you made this diagnosis.
This is he got NS1A3 positive, and the final diagnosis is dengue shock syndrome.
Ooh.
The treatment is he was admitted Repotan 6%, 500 millimeter intravenous transfusion, and after his symptom improve, included his pulse improved to 80 beats per minute. The blood pressure improved to 110/80, and the respiratory is improved. It is unfortunate that I don't have his hematocrit after Revotrang transfusion. Then he was transferred to Lata Ringer 500 millimeter, and he was discharged to hospital in the day 7 of his disease.
Amazing. Wow, this is so intriguing. And I rambled away about pancytopenia, but I just saw, Han, that his hematocrit was 50. I probably had that wrong. So his hematocrit was high when he was when he first presented? Okay. So I apologize, everybody. Even though we talked about pancytopenia, it turns out this patient has leukopenia, thrombocytopenia, but an elevated hemoglobin. And the elevated hemoglobin is the big clue here to the final diagnosis, even though it's easy to say that now in retrospect. Let me show you one quick thing, and I'll have you all reflect on the final diagnosis. But essentially, in the context of infection, an elevated hematocrit is suggestive either of just poor PO intake, but if you're trying to prioritize which infections, it really is an infection that results from vascular leak. So the vessels become leaky, they leak out fluid, but not red blood cells, and you get an elevated hemoglobin. And the infections that do that, there's 4 of them. Hantavirus, as Kushal mentioned earlier in the chat, can do it, but dengue is way more common in the whole world, including Vietnam. And of course, you might have heard of toxic shock syndrome, and there's a very rare infection called Clostridium sordelli, which can do that. So in retrospect, even though we went down the pancytopenia route erroneously, the elevated hemoglobin is a very powerful clue. And in the United States, it's usually because of pancreatitis or angioedema that causes vascular leak. But in the context of an infection, which we were zeroed in on, it really suggests one of these 2. And it turns out the more likely one, dengue, was at play here. Han, thank you so much for another absolutely fascinating case. Do you want to just tell us what you learned? What did you take away yourself from taking care of this patient?
This patient, this is first my patient when I was in the 4 years medical student, and it's the patient taught me a lot because it's my first night shift in the medical school, and I need to follow up him until 5 a.m. and the thing I learned that the dengue fever can be a fatal disease, and there in my city there was a really huge amount of case that people, especially the children who die from this disease because it is not detected early in previous year before. Um, and I learned in the case to follow up the shock, the hypothalamic shock of the dengue virus. And yes, and this is myself
Wow.
study.
Thank you so much. I can't imagine how nerve-wracking it must have been to take care of this patient in real time, and we really appreciate you bringing it over here. We want this case to be as accurate as possible when it goes on the website. Can you tell us what the hemoglobin was again? Maybe just type it into the chat. And while I do that, I'll just ask Rafa to include one other teaching point, because I feel bad that I went down the pancytopenia route, which is maybe you can add, Rafa, that the 2 infections that cause elevated hemoglobin are hantavirus and dengue as a reconciliation for my error. All right, yeah. Okay. All right, Rafa, take it away, please. Summarize the learning that you had, and thank you all for joining us. It's an absolutely fantastic journey. And quite honestly, my favorite part is just hearing from you all and learning from you all, from the mix of voices that are joining us here in the US and around the world. Thank you again. And Rafa, please take it away.
Okay, so first, thank you, Han. Like, it was an amazing case, and even though we had some turnarounds, it was really, really incredible. So we had a fever in a 9-year-old patient. First, we thought about the immediate pneumonic, which stands for infection, malignancy, autoimmune, drugs, endocrinopathy. But in a pediatrics population, we try to narrow in on infection and autoimmune diseases. Another question that would be interesting in a pediatric case is to ask ourselves if the patient is with the vaccinations up to date, any history of immunodeficiencies, selective IgA deficiency being the most common. And it's also important to find the center of the gravity when it comes to fever, like any symptoms that could localize the infection or the clinical syndrome. For example, cough could be the lungs. And then we talked a little bit about Kawasaki, which is also known as mucocutaneous lymph node syndrome. There's a 5-day of persistent fever with strawberry tongue, which is also seen with scarlet fever. We have to think about that in the differential diagnosis, but also cervical lymphadenopathy, conjunctivitis, peripheral edema, maculopapular rash, and this patient have increased risk for coronary aneurysm and thrombosis. And the treatment is IV immunoglobulin and aspirin. And it's something that I learned for step 1, that it's like one of the few exceptions that can use aspirin in a pediatric population because the risk for Ryer syndrome. Ryer syndrome, it's often followed by viral illnesses like influenza, and these patients, if they receive aspirin, that could lead to a diffuse mitochondrial insult with encephalopathy and liver failure. Then we talked a little bit about pancytopenia. Personally, I learned from UWorld to divide into 3 buckets: bone marrow aplasia, for example, secondary to viral infections, cytotoxic medications, radiation, but also bone marrow infiltration, cancer, fibrosis, granulomatous infections, and also mature blood cell destruction, like from GIC. And then finally, which was the diagnosis, we talked a little bit about dengue toxic syndrome. It's a flavivirus transmitted by the Aedes aegypti, and we can diagnose that in the acute setting with NS1 antigen positive, and it can affect many organs, including the liver, which could explain the hepatomegaly, but also the lungs with biliary effusion, and a lot of other organs as well. And it can increase the hemoglobin. It's a diagnostic clue with hemoconcentration due to the leak vasculature, but also another clues could be thrombocytopenia and leukopenia. So thank you, everyone. I hope everyone had a good time, and I hope to see everyone tomorrow.
Amazing. Thank you so much, Rafa. There were 2 final thoughts that people jumped in to share their experiences. One is Amanda was telling us is very common. Amanda, do you want to unmute yourself and just share your experience with it before we go, since we have a few minutes?
Yes, dengue fever is very common in Minas Gerais, and we have a lot of patients in the hospital because of this illness, and the support is very complicated because das reações adversas, as reações adversas with the patient has, and the virus of cause the illness is not eradicated. It's very difficult eradicating this virus, and it's very common. The patients us attending is a difficult cause to treat because they are reaction adverses. I'm sorry, I'm nervous, but I will be better to talk to you. And is this?
It's absolutely amazing. Your nervousness does not shine through, and your teaching is very, very important. I hope to hear your voice more and more next time. Thank you so much, Amanda. We couldn't end on a better note. Happy Saturday, everyone. We hope to see you around we are here every day of the week, and hope to see most of you around then, and if not, on next Saturday. All right. Bye, folks.